Acanthosis nigricans. Acanthosis nigricans is a cutaneous manifestation of an underlying condition. It usually develops in skin folds, such as the back of the neck, axilla, and groin, where it presents as velvety hyperpigmented patches with poorly defined borders. Acanthosis nigricans is most commonly associated with diabetes and insulin resistance, but rarely it can be a sign of internal malignancy. It can also occur with hormone disorders or with the use of certain medications like systemic glucocorticoids and oral contraceptives. There are multiple factors involved in the development of acanthosis nigricans. Increased circulating insulin activates keratinocyte insulin-like growth factor receptors, particularly insulin-like growth factor 1. At high concentrations, insulin may displace insulin-like growth factor from insulin-like growth factor binding protein. Increased circulating insulin-like growth factor may lead to keratinocyte and dermal fibroblast proliferation. Hereditary variants are associated with fibroblast growth factor defects. Increased transforming growth factor appears to be the mechanism for malignancy-associated acanthosis nigricans. Transforming growth factor acts on epidermal tissue via the epidermal growth factor receptor. Familial acanthosis nigricans may arise as a result of an autosomal dominant trait presenting at birth or during childhood. It occurs due to mutations in fibroblast growth factor receptor 3, FGFR3. Obesity-associated acanthosis nigricans. Obesity is one of the most common conditions associated with acanthosis nigricans. Lesions are usually common in adulthood but can occur at any age. It may be associated with insulin resistance. Treating obesity with diet, weight reduction, or medications can result in the revolvement of acanthosis nigricans. Medications associated with acanthosis nigricans. Multiple medications have been linked to acanthosis nigricans. These include the use of nicotinic acid, systemic glucocorticoids, diethylstilbestrol, combined oral contraceptive pill, growth hormone therapy, estrogen, protease inhibitors, niacin, and injected insulin. Once the offending medication is stopped, acanthosis nigricans usually resolves. Acanthosis nigricans associated with endocrine dysfunction. It is more insidious in onset, less widespread, and patients are often obese. Insulin resistance syndromes may be divided into type A and type B syndromes. Type A syndromes present with hyperandrogenemia, insulin resistance, and acanthosis nigricans. Type B syndrome usually occurs in females who have uncontrolled diabetes, ovarian hyperandrogenism, or autoimmune diseases like SLE, Sjogren's syndrome, or scleroderma. Polycystic ovarian syndrome is associated with acanthosis nigricans. Insulin resistance and hyperandrogenism are seen in patients with polycystic ovarian syndrome. Acral acanthotic anomaly refers to a variant of acanthosis nigricans limited to the elbows, knees, knuckles, and dorsal surfaces of the feet. It is common in individuals who have dark skin. Malignant acanthosis nigricans syndrome is associated with gastrointestinal adenocarcinomas and genitourinary cancers such as prostate, breast, and ovary. Lung cancer and lymphoma rarely are associated with acanthosis nigricans. Malignant acanthosis nigricans may precede, accompany, or follow the onset of internal cancer. Malignancy-associated acanthosis nigricans usually has a rapid onset and is accompanied by skin tags, multiple seborrheic keratosis, the sign of lesser Tralat, or tripe palms. Autoimmune acanthosis nigricans is associated with autoimmune disorders like SLE, Sjogren's syndrome, scleroderma, or Hashimoto's thyroiditis. Unilateral acanthosis nigricans, also called nevoid acanthosis nigricans. It is very rare and is inherited in an autosomal dominant fashion. Lesions occur unilaterally. Lesions present in infancy, childhood, or adulthood. The pathogenesis of acanthosis nigricans is likely related to growth factor levels and insulin-mediated activation of insulin-like growth factor, IGF, on keratinocytes and increased growth factor levels. The pathophysiological process behind acanthosis nigricans appears to be related to the proliferation of fibroblasts and the enhanced stimulation of epidermal keratinocytes. Patients usually present with an asymptomatic area of darkening and thickening of the skin, pruritus, and lesions that are velvety, hyperpigmented macules and patches and progress to palpable plaques. In approximately one-third of cases, malignant acanthosis nigricans presents with skin changes before any signs of cancer. In another one-third of cases, lesions arise simultaneously with the neoplasm. In the remaining one-third of cases, the skin findings manifest sometime after the diagnosis of cancer. In nearly one-third of patients with malignant acanthosis nigricans, the skin changes usually occur before any clinical signs of the malignancy. In another one-third of patients, the skin lesions develop at the same time as the presentation of cancer. In the remaining patients, the skin features occur after cancer has developed. Malignant acanthosis nigricans can appear suddenly and often is associated with intense pruritus. The lesions of acanthosis nigricans typically occur in areas of skin folds like the groin, axilla, or posterior neck. In children, the most common site of acanthosis nigricans is the posterior neck. Rarely, acanthosis nigricans may occur on the mucous membranes of the nose, oral cavity, esophagus, or larynx. Women also may develop lesions on the nipple. Rare cases of acanthosis nigricans have been reported in the conjunctiva. In some patients, there also may be associated with skin tags in the same area. Nail changes like hyperkeratosis and leukonychia may be present. Clinically, it is not possible to differentiate the lesions of benign versus malignant acanthosis nigricans. Acanthosis nigricans is diagnosed clinically and confirmed with a skin biopsy. Blood tests, endoscopy, or X-rays may be required to eliminate diabetes or cancer. It may fade over time by treating the cause, insulin resistance. Controlling blood glucose levels through exercise and diet often improves symptoms. Topical fade creams can lighten skin in less severe cases. Acanthosis nigricans malignant may resolve if the causative tumor is removed successfully. The goal of treatment is to treat the underlying disease. In the majority of patients, the treatment is done only for aesthetic reasons. In some patients, weight loss and correction of insulin resistance lower the burden of hyperkeratotic lesions. Acanthosis nigricans associated with insulin resistance can be treated with drugs such as metformin and rosiglitazone, which are insulin-sensitizing agents. All inciting agents and medications should be discontinued. One should make attempts to lower the lipid profile. Reports suggest that dietary fish and niacin may help. Dermatologists sometimes prescribe keratolytics, such as topical retinoids and podophyllin. Topical vitamin D analogs act by decreasing keratinocyte proliferation and cause an improvement of the acanthosis nigricans lesions. The success of these treatments is variable. Other agents that have been tried include metformin and etretinate. Melatonin can also improve cutaneous symptoms in obese patients with acanthosis nigricans by improving the inflammatory status and insulin sensitivity. Cosmetic treatments that have been tried include using alexandrite laser, dermabrasion, and chemical peels. Surgical removal is the main treatment for malignant lesions.